Hello students, in this session we will be discussing about previous year questions. So these are mostly recall questions and whatever has been coming in the exams. So we'll try to cover as much as possible. So starting with the latest, which is NEET PG 2021, the questions that came in this exam were: a male patient presented with itching of scalp and hair infection. Hair perforation test was positive. So which is the causative organism? So they had given you some history which suggested of tinea capitis, because they had said itching in the scalp, hair infection, and also the options which were there, you knew that they're talking about some kind of fungal infection. So this was more of a microbiology and a derma integrated question. The important relevant thing that had been given to you was hair perforation test being positive. So hair perforation test is positive in Trichophyton mentagrophyte. So this is what they wanted to ask you, and that is the relevance of giving this question. So as we have always stressed that nowadays the questions are not direct, but they try to integrate it. So they told you that it was tinea capitis and hair perforation test was positive. Now you must have studied about hair perforation test, that this is usually used to distinguish between various isolates of dermatophytes and in particular Trichophyton mentagrophytes. So what we do is we take hair we cut short hairs from the pubic area, and then we inoculate it and incubate it at room temperature. Then we remove the individual hairs at 4 weeks and examine them under microscope in lactophenol blue. Now isolates of T mentagrophytes, they produce localized areas of pitting, whereas those of T rubrum do not. So now why this? Because these days earlier T rubrum was one of the most commonest causes, but these days T mentagrophytes is emerging to be a common cause, and so to differentiate between these two, we use this hair perforation test. So hair perforation test is for Trichophyton mentagrophyte. Another question which was there was: a patient presents with paronychia and extensive wheel-like infection pattern which was linear on the upper limb. So they had given you an image of a phelon. What's a phelon? The little finger, the inflammation or paronychia of a little finger is a phelon, and then they had given you a linear lesion like this, linear lesion like this. A lot of you confused it with dermatographism, but remember that when they're talking about an infection of any of the digits followed by a linear inflamed swelling, that is usually suggestive of lymphangitis. So they were talking there about lymphangitis, and they wanted to know the suitable antibiotic for the treatment. Even if you were not sure whether they're talking about acute lymphangitis, if you see any infection and you look at the options, they're talking about which is the common antibiotic that you will use in cases of these infections. So that you have studied, we have discussed that amoxiclav is one of the commonest antibiotics that we use for any kind of skin infection. So here there was paronychia followed by lymphangitis, and so here my option would be amoxiclav. So though they tried to confuse you with the picture, but the options were pretty much clear that you have to choose a suitable antibiotic, so you know they're dealing with some kind of infection, and we know that amoxiclav is the answer. Now acute lymphangitis, just to brief you, is a streptococcal infection of lymphatic vessels, and it presents with a linear inflamed erythematous streaks, and which can vary from width, and it usually follows a portal of entry, and it represents that my regional lymph nodes are being involved. So this is acute lymphangitis, and in treatment of bacterial infection, we know that if it's a very localized folliculitis or something, we can do with topical management. But here when I have lymphangitis, I know I need systemic antibiotics, and these are my common classes of systemic antibiotics that we use. So in the options that were given, amoxiclav was a clear-cut choice. Now, next question. A truck driver came with complaint of painless genital ulcer after safe intercourse. So a painless genital ulcer after unsafe intercourse. So we are talking definitely about an STD genital ulcer, and this genital ulcer, as mentioned, is painless. Now, the next part of the question was the motility of the causative organism can be best checked by which type of microscope. Now, I'm not too sure whether they wrote motility or not, but in case they have given you motility, we know that in the genital ulcers that we have studied, what were the 5 main causes? We had talked about syphilis, chancroid, herpes genitalis, donovanosis, and LGV. So you have to differentiate between these. Now, they've given you a painless genital ulcer. Chancroid is ruled out, herpes genitalis is ruled out, and even donovanosis may be painless, but they would give you more history. LGV hardly presents with an ulcer. So, for LGV, they will always talk about a swelling in the inguinal region. So, this is again ruled out. So, painless, we know we are dealing with either syphilis or we are dealing with donovanosis. Now, in the question, if they tell me motility, we look for motility of only Treponema pallidum. Rest of them we stain with Gram stain or Zang stain. We stain with them. But it is Treponema pallidum which cannot be stained. So what we do for it? We do a dark ground microscopy or dark ground microscopy, yes, to look for motility. So in a dark background, we look for these fluorescent spirochetes and we look for their motility. So here, painless genital ulcer, whenever they give you painless genital ulcer, they're very, very commonly, 99% of the times they're talking about syphilis. And with syphilis, we know that syphilis is caused by Treponema pallidum, which is an organism which is non-cultivable, which cannot be stained by the normal routine staining procedures. And so here what we do is a dark field microscope. We do a dark field microscopy or dark ground microscopy, which is done with this. Here, the whole of the background is black and the organism appears like this. It appears as wavy fluorescent organisms, which is motile. Okay, and what is the classical motility of Treponema pallidum? It's corkscrew rotation. So corkscrew rotation is one of the commonest motility that we see, and also propulsion. Right? So it was again a very clear-cut question. Moving on, again a question from STD. A migrant laborer came with complaint of urethral discharge after 1 week of unprotected sexual intercourse. So we know we are dealing with STD whenever they talk about unprotected sexual intercourse. 1 week. So my incubation period is 1 week. And what is my presenting complaint? Presenting with urethral discharge. Okay. Now, we remember that when we talked about urethral discharge, we said that there were broadly 2 main causes. It was gonococcal urethritis or non-gonococcal urethritis. We know this. Now, gonococcal urethritis, we know is caused by Neisseria gonorrhea, whereas non-gonococcal urethritis is caused by chlamydia, ureaplasma, mycoplasma, Trichomonas vaginalis, and even herpes simplex virus. All this can cause NGU, right? Now, how did we differentiate between GU and NGU? Now, in the question, they didn't give you anything. They just said urethral discharge, 1 week, and what is the causative organism. But they had given you an image which was quite explanatory. Now, in the image, look at the kind of discharge. The discharge is... Look at the kind of discharge here. The discharge is thick and yellowish. Thick, yellowish discharge. I cannot comment anything else looking at the image. From the image, I can just see that there is a thick discharge, there is a yellowish discharge. Now, thick yellowish discharge is a characteristic of gonococcal urethritis. Okay. And gonococcal urethritis is caused by Neisseria gonorrhea. So here my answer would be Neisseria gonorrhea. Now, even if I look at the other options, ureaplasma, trichomoniasis, all that causes NGU. So, they are asking you about one causative agent. And you know that NGU is caused by, even from the image, suppose you got confused and you're not sure whether this is NGU or GU. If you look at the options, there cannot be two options which can be marked in this. So, here there has to be one answer. So, you should look at you think about what the kind of discharge is. And if you look at the discharge, it was thick purulent discharge, and so the answer would be Neisseria gonorrhea. So incubation period is also short, 2 to 5 days. In the history, usually sometimes they give you history of urinary symptoms or constitutional symptoms. I'm not sure whether it was provided you or not, but even if the image was something like this, see, the image was something like this, thick purulent discharge. How would the NGU discharge looks like? Something like this. So it's watery, it's scanty. So again, scanty, you will not be able to make out just with this image, but you can make out it's watery. It's not thick, it's a thin, watery, transparent kind of a discharge. Whereas my gonococcal urethritis is thick purulent discharge. So from the image, you should be able to make out that they are talking about gonococcal urethritis. And so my answer would be Neisseria gonorrhea. Okay. A patient of 30 years came with flaccid bulla on her skin, which are easy to rupture. Biopsy revealed suprabasal split. What is the diagnosis? Again, a very, very easy question. Flaccid bulla. Now, if you remember, we'll go back a little. So, when we talked about our immunobullous disorders, so from the question, you know that we are talking about immunobullous disorders, even looking at the options. Now, the immunobullous disorders we studied were of two types, intraepidermal and subepidermal. Broadly, how do you differentiate between intra and subepidermal disorder? Clinical feature, that here my bulla would be flaccid. I have flaccid bulla which rupture easily. Here I have tense bulla. Then what were the other features? This is my clinical feature. Then if I do a Nikolsky sign, it is positive here, it is negative here. If I make a Zhang smear, I see acantholytic cells here and I see no acantholytic cells. I can see neutrophils or eosinophils. So usually whenever they're giving you a question on immunobullous disorder, they would first want you to classify between intra and subepidermal disorders, right? Now, so if they're talking about flaccid bulla, you know I'm dealing with intraepidermal disorder. Okay, now I think of all the pemphigus group of disorders. So intraepidermal disorders are pemphigus group, subepidermal are pemphigoid group. Now, even if I look at the options, they've given me all options of pemphigus. Now, what will help me differentiate? So this is just to tell you that maybe there were other options. So you should be clear that first intra and subepidermal. Now, once we are clear that it's an intraepidermal disorder, what other information is the question giving me? It is telling me that my split is suprabasal. Now, in intraepidermal, we have discussed, or you must have read, that intraepidermal we have to broadly divide into pemphigus vulgaris and pemphigus foliaceus. Now, foliaceus is desmoglein 1. Here, my split is subcorneal. It's very superficial. Pemphigus vulgaris is predominantly 3, but it also can be desmoglein 1. And here my split is suprabasal. Right? Then what were the other differences? In pemphigus vulgaris, I had mucosal involvement, which was not present in pemphigus foliaceus. Here in pemphigus foliaceus, I see mainly crusted erosions. You may see some bulla, but predominantly crusted erosions in seborrheic distribution. Here I see flaccid bulla. So this is how broadly you first differentiate between intra and subepidermal, and then you differentiate between vulgaris and foliaceous. So here in the question, they have told you that it's a suprabasal split. Now, suprabasal split is seen in pemphigus vulgaris, not in foliaceous, not in EM. Foliaceous, I see a subcorneal split. With EM, I might not see a split. What I see is a more of interface dermatitis. Now, vegetans will not present with flaccid bulla. Vegetans will present with vegetating lesions. Okay, so vegetating lesions on the groins, on the flexures. So in the question, they will not give you flaccid bulla. So my answer here would be pemphigus vulgaris. Okay, just to make things easier for you, look at this histopath. So here I see a suprabasal split just above the basal layer. Here I am seeing a subcorneal split. Subcorneal split, pemphigus foliaceous, suprabasal split, pemphigus vulgaris. So you should be able to differentiate between these two based on these clinical features. Very commonly you get questions related to immunobullous disorder, and if you broadly remember this, you will be able to answer most of the questions. Coming next, girl child presenting with rough lesions over her elbows and knees on extensor surfaces. I have rough lesions and have a problem of night vision. Again, a very, very clear-cut question. So the problem of night vision clarified everything. So if there is a problem of night vision, we know we are dealing with vitamin A deficiency. And we know what happens in vitamin deficiency in skin. We have toad skin or phrenoderma. And if you know what is that, what is toad skin? Toad skin means rough skin, phrenoderma. It's also called as phrenoderma. Now, this toad skin or rough skin presents with rough hyperkeratotic lesions which are there on knees and elbows. Okay, so here what am I dealing with? I'm dealing with phrenoderma. So problem in night vision was a giveaway. Otherwise, if they had just given you this image, you might have got confused whether it is KP, whether it is some PRP or anything else, any hyperkeratotic lesions. But here the problem in night vision tells me that they're talking about vitamin A deficiency, and we know the skin manifestation of vitamin A deficiency is phrenoderma or toad skin appearance. Now, they might even ask you, the phrenoderma now is known to be a result of lot of deficiencies, not just vitamin A, even essential fatty acids, other vitamins and minerals deficiency. So now it's not strictly localized to vitamin A deficiency. But here the question was about vitamin A deficiency, and we know the earliest sign is night blindness and earliest skin manifestation is dryness, and patient typically presents with these hyperkeratotic lesions which are usually asymptomatic on knees and elbows. This is called as phrenoderma or toad skin appearance. Clear? Okay. A male child complains of mild, painful, boggy swelling. Now, painful, boggy swelling in dermatology only means chorion. You will not, for your sake, you will not hear this term with anything else. Boggy swelling on the scalp, boggy swelling in the scalp, I have emphasized this a lot of times, is nothing but a chorion. Don't get confused. If they give you this description, they are talking about chorion. Now, another thing that they gave you was pet animals are there in the home. What is the significance of that? Now, chorion, why is it so inflammatory? Why do we have this boggy, painful swelling? Because it is caused by zoophilic species of dermatophytes. Now, dermatophytes can be anthrophilic, zoophilic or geophilic. Now, chorion is caused by zoophilic species of dermatophyte. Now, zoophilic means which is transferred from animals to humans. Okay, so we know that chorion is caused by Trichophyton verrucosum and Trichophyton mentagrophytes. Now, this is a zoophilic species transferred from animals to humans. So, pets at home means their source of infection was that pet who carried the zoophilic species which got transferred to the male child, and that lead to this. And then, so there are two important giveaways, boggy swelling and pet animals. So, both of this tells me that it is a chorion. Now, let's look at the other option. options, folliculitis. It cannot be folliculitis. Folliculitis would be single, pinpoint follicular pustule which may be present. Now here you have a whole boggy swelling with crusting, with matting of hair. Abscess. Abscess is usually a closed encased cavity. Usually my upper skin is normal, my normal epidermis, and then there is a painful swelling which is there. Epidermal cyst is usually not painful, and again it is a cystic swelling that you see. So painful boggy swelling with pet animals on scalp is nothing but a carry on. Very, very clear cut question. So coming to INICET November 21, a rose gardener following prick injury develops the following skin changes. What is the causative organism? So what is the significance of rose gardener? Rose gardener means that a person who works in a rose garden is prone to injury from the thorns. What happens if there is an injury from a plant thorn or a vegetative material? It leads to subcutaneous mycosis. We have talked that subcutaneous mycosis is caused by implantation injury. So there has to be an implantation, and usually it is seen in gardeners and farmers who get thorn prick. Now rose gardener is in specific terms relevant to my sporotrichosis. In fact, sporotrichosis is also called as rose gardener's disease because it is commonly seen in rose gardeners. So if they give you a rose gardener, you know that we are talking about sporotrichosis because sporotrichosis is also called as rose gardener's disease. Now, what is the skin change that they are showing you? They are showing you a linear kind of a lesion with not a linear lesion, nodules, subcutaneous nodules showing crusting at places which is present in a linear arrangement. Now, this is suggestive of a lymphangitic spread, which again I know is seen in sporotrichosis. Okay, so I have these subcutaneous nodules arranged in a linear arrangement, which is suggestive of a lymphangitic spread. I have rose gardener, so I'm talking about sporotrichosis. Here, they're not asking you the diagnosis. They're asking you what is the causative organism. So, if you know sporotrichosis, you know my organism is Sporothrix kenkai. You do not even need to look at the other options. Sporothrix kenkai. So, two important giveaways, rose gardener's disease and presence of this lymphangitic spread. Okay, so this is how it presents with. Two other things that are asked. So, here we get cigar-shaped bodies on past stain and we get asteroid bodies on histopathology. This is also asked about sporotrichosis and its treatment. So, we give potassium iodide, you can give itraconazole and you can give terbinafine. These three are used for treatment of sporotrichosis. Again, you do not even need to look at the question, you do not even need to read the question. You see the image, they're just asking you for diagnosis. So even if I don't look at the question, I know what it is. So a patient who presented with vesicular lesions distributed on a single dermatome also complains of pain in the same region. What is the diagnosis? When I look at this image, I see a typical dermatomal distribution. So, dermatomal distribution with vesicles showing crusting present on one side of the body. What is it? It cannot be anything else except for herpes zoster. So, herpes zoster we know is an infection which is caused by varicella zoster virus. It is basically reactivation of the latent virus which leads to herpes zoster, and a very characteristic feature of herpes zoster is dermatomal distribution. So I have lesions which are present along a dermatome and they are extremely painful. So dermatomal painful lesion in dermatology for you is nothing but herpes zoster caused by varicella zoster virus. And another important thing that you need to know, which I have already pointed out, that herpes zoster is because of reactivation of this virus. Reactivation of virus. It's not transmitted from one person to another. So it is a reactivation of virus. A lot of times they ask you a question which is related to this. So any similar painful lesions present in dermatomal distribution, you please go ahead and mark herpes zoster. right? HIV, again, no specific skin lesions. Herpes simplex will present with coalescing vesicular lesions, which can be present on different parts of the body, but dermatomal, no. Lymphangioma is not painful. Lymphangioma is a abnormality in the lymphatics, and that leads to small vesicular lesions which are present at a particular area of the body. But they are usually not painful, and they may not be necessarily dermatomal, right? Okay, a 60-year-old presents with tense itchy blisters which settle after some time. Image is shown. So now here, as we've already discussed, if they're giving me tense blisters, I know I'm talking about subepidermal disorder. Not discussing that again. We are clear that we are talking about subepidermal disorder. Look at the options that I have. Now, subepidermal disorder is a pemphigoid group. Is the pemphigoid group. Intraepidermal is pemphigus group. So, obviously, pemphigus vulgaris is ruled out. Okay, I'm sorry, this must be IgA pemphigus. IgA pemphigoid is not there. So, pemphigus is ruled out. Now, we are left with bullous pemphigoid and DH. Now, if you remember in subepidermal disorders, we always said that there is a pemphigoid group and there is dermatitis herpetiformis. Why is DH different? Because it does not present with blisters. It presents with itchy excoriated papules. So, here I have tense blisters. Another important giveaway. So, tense blisters subepidermal in the options given, bullous pemphigoid is my answer. Even if they had given you other options like EBA or any other pemphigoid group of disorders, how do you differentiate here? Another very important pointer is presence of itching. So, when itchy blisters are there, itchy tense blisters is again a characteristic of bullous pemphigoid. In bullous pemphigoid, there is recruitment of eosinophils. So, there is usually a pre-bullous stage also where patient presents with itchy urticarial lesions on the body. And even if it presents with blisters, because of that eosinophilic recruitment, there is itching around the blisters. So, in my immunobullous disorder, if you're talking about the pemphigus group, there I usually do not get itching. I get more of burning sensation. In bullous pemphigoid, on the other hand, I see more of itching. So, I have itchy lesions. I have urticarial lesions which may be present around the tense blisters. So, usually when they talk about bullous pemphigoid, one, they give you tense blisters, and second, they tell you that there is an itchy erythematous or urticarial base, which again points out that yes, we are talking about bullous pemphigoid. So, again, no confusion. Look at the image. Don't look at the image. The question is self-explanatory, but if you look at the image, you see these tense blisters and then you see these urticarial erythematous lesions surrounding these tense blisters, which is suggestive of bullous pemphigoid. Okay? Okay. A child presented with whitish lesion on elbow and penis, penile shaft as shown in the image below. Now, what is the diagnosis? So, what I see here is very, very shiny pinpoint lesions, which they tell me is present on elbow and penile shaft. Whitish. So, whitish lesions would mean very shiny pinpoint lesions. Let's look at the options. Lichen planus. Lichen planus we know presents with 5 Ps, and so the lesions are not whitish, they are purplish lesions. Scabies. Scabies can present with penile shaft lesions, with elbow lesions, but whenever they talk about scabies for you, they will give history of itching or family history, and they are not usually such monomorphic lesions that I see in scabies. What I see is more of excoriated papules. Also, if you look carefully, there is presence of Koebner's phenomena here. Okay. Lichen scrofullosorum. Lichen scrofullosorum is a type of tuberculid, and it is present on trunk. It can present with small micropapular lesions, but this is present on trunk. So now what we are left with? Lichen nitidus, and that is the answer. That is the answer. What is lichen nitidus? It is basically it has very clearly defined clinical and histopathological criteria. So we know what it looks like clinically and histopathologically. But you ask me what is the exact etiology, what is the exact pathogenesis, that is still unknown for it. It is considered by some to be a variant of lichen planus. Important point about lichen nitidus is it is seen in children usually. So lichen nitidus, they'll give you a child, and it will always present with multiple shiny flat-topped, pale to skin-colored papules, and they are present on limbs, abdomen, chest, and penile shaft. So typically, they present with shiny, flat-topped, skin-colored papules. They are present on elbows. They can be present on abdomen. They can be present on penile shaft, and they are usually asymptomatic. So no itching. Usually, they are asymptomatic. So we usually do not need any treatment unless they're very symptomatic. So lichen nitidus. And what is the classical histopath appearance that we see here? We see ball in claw. So it's like this. It's like this. There's an inflammatory infiltrate and my epidermis is sitting like this. So it appears like ball in claw hand appearance. Okay, so that is a typical histopath feature that we see with lichen nitidus. Now, a 45-year-old patient from Bihar presented with hypopigmented lesions over the neck. So one thing, resident of Bihar and then has hypopigmented lesions over the neck. There is no hypoesthesia. If they mention that there is no hypoesthesia, they're basically helping you rule out leprosy. They are basically helping you rule out leprosy. Remember this. They will specifically mention this if they want to rule out leprosy. No hypoesthesia, no nerve thickening. So they are telling you don't think about leprosy. So strike out leprosy from your options. History of prolonged fever and nodular lesions on the face in childhood. Prolonged fever and nodular lesions. So what is the most likely diagnosis here? Here, this is a sequelae of cutaneous leishmaniasis, which is called as post-Kala-Azar dermal leishmaniasis. So it's a variant of leishmaniasis, it's not a sequelae of cutaneous leishmaniasis, it's a sequelae of Kala-Azar. So it's called as post-Kala-Azar dermal leishmaniasis. So history of prolonged fever tells me it is Kala-Azar that the patient had in childhood. So Kala-Azar happens 10 to 20 years before. But if you ask them, they give you history that there was prolonged fever. They might give history of swelling in the abdomen, which is basically hepatosplenomegaly that can happen. And PKDL to begin with. So what did I tell you? It's a sequelae of visceral leishmaniasis, and you get history of Kala-Azar in the form of fever, hepatosplenomegaly. What are my common agents? Sometimes they ask you this, that what is the causative organism here? So L. infantum, Chagassi, and more importantly, L. donovani. And this is an endemic condition. So PKDL you usually do not see around the world. You would in fact read this about in Indian textbooks only. So this is endemic to India, and we see it more commonly in the states of Bihar, in Bengal, in Orissa. Now, how does the patient present with? Patient can have 2 or 3 manifestations. So, one patient can present with this raindrop hypopigmented macules which are present, can start from the face, then come on the neck and on the trunk. They have no loss of sensation. There is no nerve thickening. It's not leprosy. Okay, so hypopigmented lesions. And they can present with nodular lesions which are present on the muzzle area of the face and with the butterfly rash. So, in the question, they had told you history of Kala-Azar by giving you history of prolonged fever, nodular lesions on the face, and now I have hypopigmented lesions. So, no atopic dermatitis does not correlate. There's no itching. Tuberculosis, again, no correlation here. PKDL is my answer here. They've told me that there is no hypoesthesia, no nerve thickening. Otherwise, whenever we think of hypopigmented lesions, we think of leprosy. But when they tell you in the exam about these two things, you rule out leprosy. So, this is a clear-cut case of PKDL. Okay, this was interesting. Identify the correct statement about leprosy if leprosy is untreated. Now, I'm not sure about the options because this was not a very direct question, so you people could not give me direct options, but whatever we had, so we are dealing with that. So, let's talk briefly about what is the, this is basically a question about the natural course of leprosy. So, what is the correct statement? Half of the people got their symptoms regressed spontaneously after bacillary exposure. So, do you know, after bacillary exposure, 95% of individuals do not get any symptoms. So let's briefly look at the natural history. So when there is a contact with any source, you develop a subclinical infection. Out of that, almost 95% will not develop any disease. Only 5% will go into an indeterminate stage. From that indeterminate stage also, 70% of patients would self-heal and 30% will go into more polar or more definite spectrums. Right? Now, another important thing that you should be knowing, so most of those exposed to infection, as I told you, over 95% are not susceptible to leprosy and do not develop disease. Okay? Now, then the question talks about spontaneous healing. So our textbook mentioned that spontaneous healing may occur in indeterminate lesions and also in early TT and BT. But the proportion of cases of each sort that heals depend on manner of classification and intrinsic immune response. So TT, BT, indeterminate, they can all go into spontaneous resolution. But who will go will depend upon immune response of the patient and how are we classifying it. Are we classifying it as indeterminate or TT? Then another thing before we answer the question, there are a lot of difference between adult leprosy and childhood leprosy. What are the differences? Incubation period in children is short. They are usually paucibacillary infections. Most common type here is mostly indeterminate. The self-resolving skin lesions or spontaneous resolution is common in children but uncommon in adults. Then, pure neuritic, histoid, lazarine leprosy, which are rare types of leprosy, are less commonly reported in children. Reactions are rarer. Okay? So, it's more common to have reactions in adults. Deformities are rare. So, deformities, reactions, rare types of leprosy, they're all rare. So, childhood leprosy is good prognosis leprosy. Then, so now come back to the question here. Half of the people got their symptoms regress spontaneously after bacillary exposure? No, it is more than 95%, not half. Spontaneous remission is more common in children than in adults. That we just saw. Yes, it is more common in children. Indeterminate leprosy resolves more often than tuberculoid. As I pointed out, there is no clear-cut data. So, we cannot say with certainty that indeterminate leprosy resolves more often. Even tuberculoid, early TT and BT may resolve depending on immune response of the patient. The fourth option, spontaneous remission is not seen, is not correct. We are talking throughout about spontaneous remission in leprosy. So, spontaneous resolution is more common in children, seen in indeterminate TT and BT pole, and 95% of the individuals who get contact with the leprosy patient do not develop any disease. Right? So, this is more about the natural course and epidemiology of leprosy. Now, another interesting question, match the following: celiac, sprue, radiation exposure, dermatitis, and scleroderma. Now, if I know this was a little tricky question, but let's simplify it. Now, if you look at these options, you know clear-cut that scleroderma is thickening of skin. It is thickening or hardening of skin. So, there is no doubt that scleroderma will be associated with hardening of skin. So, this option is ruled out. Now, I have three options from which I have to rule out. Now, if you remember celiac sprue, what was celiac sprue? It was associated with dermatitis herpetiformis, and in dermatitis herpetiformis, there is atrophy of ridges, right? So, celiac sprue is associated with atrophy of ridges. Whenever there is radiation exposure, if there is significant radiation exposure, radiation always causes damage, complete damage. So there is permanent loss of ridges. Dermatitis, on the other hand, causes some alterations of the ridges. Now, what are ridges? Do you know what are ridges? So, when we talk about our skin, it's something like this. And then here, I have my dermis. So, this invagination of epidermis into the dermis is called as ridges or rete ridges. So, rete ridges are part of epidermis. They are epidermal invaginations into the dermis. What are these then? These are my dermal papilla. So, part of dermis which is going into the epidermis is called as dermal papilla, and part of epidermis which is invaginating is called as rete ridges. Okay. So, here let's look at the option A2, B3, C1 and D4. So, here A is my correct option. So, epidermal ridge atrophy is a very, very characteristic feature of celiac sprue and is seen in almost 90% of the patients. Okay, and in radiation, so in celiac sprue, I see epidermal ridge atrophy. Then, with radiation, everything is permanently lost. There is permanent loss. So, if there is severe radiation, there is permanent loss of rete ridges. Then, in atopic dermatitis, I have elongation of rete ridges. Okay, so there's some alteration that is seen. Whereas scleroderma causes thickening and so hardening of rete ridges. So, though a little confusing, but if you look at the options and if you try to derive the answer out of it, it is not that difficult. Alright. So, that brings us to the INI July 2021. Here, the first question was, a female comes with unilateral lesions as shown in the image. She also has leukotrichia. I have unilateral lesions, I have leukotrichia, and I have, what are we seeing? We are seeing depigmented macules. Depigmented macules, and this, if you look at, is present in a segmental distribution, and there is associated leukotrichia. What is it? It is definitely segmental vitiligo. Let's look at all the four options, then you will be able to know. So, all the four options that were given to you were this. So, what is this? The first one, where I see a single hypo to depigmented lesion which is present on the trunk and it's not completely depigmented. See, this is my nevus depigmentosus. Here, what do I see? A triangular, almost a triangular patterned leukotrichia, patch of depigmentation, leukoderma with leukotrichia, which is seen, and I see some islets of hyperpigmentation. Three features: leukotrichia, triangular patterned leukoderma, and islets of pigmentation. This is my piebaldism. Then here, what do I see? A single lesion which is depigmented. This is my focal vitiligo. Here I see depigmented macules and segmental distribution. So, this is my segmental vitiligo. So, if you look at these four images, they are very, very different. They are very clear. And in the question also, it's giving me a unilateral. Unilateral can be here, can be here. Depigmented lesions you can see, and the presence of leukotrichia, which is very characteristic of segmental vitiligo. So, no, it's not ND, no, it's not piebaldism, it is segmental vitiligo. Segmental vitiligo, you get lots of questions, so you should know few important features about segmental vitiligo, that it is not autoimmune in nature. My neurogenic hypothesis supports its development. It is present along a dermatome or segment, usually seen in children, so early age of onset, has a very stable course, and there is frequent association of leukotrichia here. There will be no Cobden's phenomena, and these patients usually do not respond to medical or phototherapy. You have to go for surgical therapy here because there is no autoimmune response. What will you target? So, here there is neurogenic hypothesis, and so you need to do surgical treatment here. Clear? Now, a child presented with itchy plaques which are present over neck, bilateral popliteal and cubital fossa. So, you have flexural involvement and you have itchy lesions. These are the two things in a child. What can it be? A child with flexural itchy lesions. That's what is given to me in the question. Let's look at the options. We'll start from below. Psoriasis. Psoriasis is not itchy, rules out. Pemphigus vegetans. Yes, it can present with flexural lesion, but is it seen mostly in children? Does it present like this? No, vegetans will present with vegetating lesions, not something like excoriated itchy papules. DH. DH can present with itchy lesions, it can present in a child, but what is the distribution of DH? It is present on extensors. It is present on extensors, not typically on a flexure. So, a child with itchy lesions on flexures, again, make a point of it. They will be mostly talking about atopic dermatitis. They could have also given scabies as an option. They could also have given scabies as an option. Then what would you have done? Scabies can present with itchy lesions in a child. It can have flexural distribution. But is scabies typically flexural? No, you have this extensors involvement also. So when they talk about itchy flexural lesions in a child, only think of atopic dermatitis. Because in child, we know there is flexural distribution. In infants, on the other hand, in atopics, where do we have the distribution? We have it on the extensors because infants crawl. Child doesn't crawl. So the more chances of allergens being here on the flexures is common. So in infants, in atopic, we have extensor involvement. In childhood, we have more of flexural involvement. Plus, they have given you an image where I can see a subacute dermatitis happening. This is clear-cut atopic dermatitis. Okay. This was interesting. A patient present with lesions as shown. What is the diagnosis? So when you look at the options, you know that we are dealing with leprosy. There's no doubt about it because they've given me all options of leprosy. Now in leprosy, with each spectrum, there is a classical lesion which is described and you should be knowing about it. So first let's see that. So what is this? This is my TT leprosy. My TT leprosy. And what do I see in TT leprosy? I see a saucer right way up. A saucer right way up kind of a lesion, something like this. I have a lesion, infiltration, and there is a raised margin or a dry anesthetic patch like this. I'm not talking about history because in the question they have not given me history. They've just given me an image and I have to find it out. So this is my TT which presents with saucer right way up. This is my BT which presents with pseudopodia and satellite lesions. So I have these pseudopodia and I have these satellite lesions. This is BT. Then what is this? This is my BL, where I see an inverted saucer appearance. Inverted saucer. Saucer is like this. An inverted saucer is something like this. Now, so inverted saucer appearance is seen in BL more commonly. Then I see dimorphic lesions, punched out lesions, Swiss cheese appearance lesion, which is seen in both BL and BB. But if they talk about inverted saucer, it is more common in BL. If they specifically say punched out or Swiss cheese appearance, they're more commonly talking about BB. Then what is this? This is BB, where I see geographic lesions and I see a annular lesion. Annular lesion is usually dimorphic. Dimorphic, both the spectrum. So in borderline, the patient is confused. So both the spectrums. And I see geographic pattern. Map-like configurations of lesions. Geographic or map-like configurations. So sometimes they give you these terms and they want to ask you what it is. So this is again. So this is my saucer right way up. This is my punched out lesion. This is my annular lesion and this is my inverted saucer lesion. And then how does my LL present with nodules, leonine facies? In the question here, what they have given you is a lesion with central clearing and something like this. So I have a annular lesion here. Where would I see annular lesion? Would I see it in BT leprosy? In BT leprosy, what was there? Pseudopodia and satellite lesion. Lepromatous leprosy, leonine facies, nodular lesions. Histoid leprosy presents with small nodules. I see annular lesions in borderline leprosy. Annular, dimorphic, Swiss cheese, punched out. All this I see in borderline leprosy. You can get confused between BB and BL because there are overlapping features. So usually in the options, they will not give you both. And if they give you, they will give you a specific thing. So if they talk about inverted saucer, you know we are talking about BL. If they are saying punched out or Swiss cheese and both borderline and borderline lepromatous is there, I told you have to mark BB. Okay, but usually they do not confuse you so much. So here they wanted you to identify that what's seen is basically an annular lesion, which is a characteristic of borderline leprosy. Borderline tuberculoid is also a type of borderline leprosy, but if they've mentioned both in the option, so with BT, I would go more with pseudopodia and satellite lesions. If I have annular lesions, I'll mark broadly borderline leprosy, which will talk about BB and BL. Okay. A child comes with patchy hair loss with itching and scaling on the scalp. So I have a patchy hair loss. So whenever I have a patchy hair loss, there are few DDs that I have to think of. What are those DDs? I have to think of tinea. I have to think of alopecia areata. I have to think of trichotillomania. And I think of moth-eaten alopecia. Right. So these are the common DDs of patchy hair loss when we talk about patchy hair loss. So now, tinea, what would be there in tinea? There will be itching, there can be scaling, and my KOH will be positive. What will happen in alopecia areata? I will see very smooth patches, asymptomatic, and there would be presence of exclamation mark here. In trichotillomania, what will be there? Hair shaft of various lengths and presence of, in the question they will give you presence of some psychiatric ailment. Moth-eaten alopecia, something which is related to my secondary syphilis. So something in the history would be related to that. Now let's go back to the question. So I have a patchy hair loss with itching and scaling. Itching and scaling is seen only in tinea capitis, not in other forms of patchy hair loss. So what is the next best step? So patchy hair loss, itching and scaling, I know I'm dealing with tinea capitis. My best step would obviously be KOH mount. I'll not do a gram stain, I'll not do a biopsy, I don't need to do a slit skin smear. I need to do a KOH mount to prove that it is tinea capitis. So look at the question, try to identify what are the different DDs and how do you differentiate between them. Anything like this, you know I'm dealing with tinea capitis, and what type of tinea capitis it is? It's mostly a grey patch kind of tinea capitis that has been shown in the question. So we do a KOH mount, there is scaling, take a KOH and you would know that we are dealing with tinea capitis. Okay, a patient comes with painful vesicles on genitalia. What will the histopathology or probably a smear show? So I have painful vesicles. If I have painful vesicles on genitalia, what would be my DD? My most common DD is herpes genitalis. Herpes genitalis would present with painful vesicles on the genitalia. What do I do for the herpes genitalis? If I do a Zank smear or if I do a biopsy, I see multinucleate giant cells or MNGs. See, I'll show you all the histopath findings that they have referred to. What is this? This is a multinucleate giant cell formed by coalescing of multiple macrophages, and I see acantholytic cells. So in herpes, what do I see? In herpes simplex, I see MNGs or multinucleate giant cells, and I see acantholytic cells. What is this? This is what I see in molluscum contagiosum. I see these invagination and I see these eosinophilic eosinophilic inclusion bodies, which are called as Henderson-Peterson bodies or molluscum bodies. Henderson-Peterson bodies or molluscum bodies. But in the question they had given you painful vesicular lesions. Molluscum is neither painful, neither vesicular. No pain and there is no vesicles here. So that's completely ruled out. Henderson-Peterson bodies or molluscum bodies are seen in Molluscum contagiosum. What is this? These are my coelocytes. Clear looking cells. Clear looking cells. Where do I see them? I see them with HPV, which causes what? Which is again painless, which is again non-vesicular. So when we look at the options here, cells with clear halo around the nucleocytes, seen with warts. Henderson-Peterson and molluscum bodies are seen with molluscum. All of these are painless. They do not present with vesicles. So I know I'm dealing with herpes genitalis, and what I'll see is multinucleate giant cells or acantholytic cells also I can see. Okay, moving on. Okay, the most specific and typical sign of juvenile dermatomyositis in 17-year-old patient. Now, specific and typical sign. When we talk about DM, there are pathognomic lesions and there are specific lesions. Now here, when they talk about most specific and typical sign, they are talking about my pathognomic lesions. Pathognomic lesions. What are my pathognomic lesions? There are two pathognomic lesions with dermatomyositis, Gottron's papules and Gottron's sign. Gottron's papules and Gottron's sign are my pathognomic features of dermatomyositis. So let's look at the option, a photosensitive rash. Photosensitive rash may happen in DM, but it's more of a specific finding. I see heliotrope rash. I see heliotrope rash around the eyes that can be seen, but it's not the most specific and typical. Nail bed capillary changes can be seen with DM. Again, comes under specific category. Malar rash is specific for SLE. Gottron's papule is typical for DM. So in DM, remember, there are lots of signs. You will see heliotrope rash, you can see V sign, shawl sign, holster sign, mechanic's hand. They are all specific lesions of DM. But when they talk about most specific and typical, they are talking about pathognomic lesion. And there are two pathognomic lesions, Gottron's papules and rash, which are seen here in the interphalangeal joint and metacarpophalangeal joint. If they appear at papules, they are called as Gottron's papule. And if I see a confluent macular violaceous erythema, I call it Gottron's rash or Gottron's sign. Okay, so these are my cutaneous manifestations of DM. So I told you pathognomic is Gottron's papules and signs, and others are characteristic, where I have heliotrope rash, periangular telangiectasia, CMV on other parts of the body, mechanic's hand. These are all characteristic, but when they talk about more specific and characteristic, they are talking about pathognomic lesion. Okay, an adult male with the history of visiting forest recently developed the following lesion. Which of the following is not a differential diagnosis? Now here I have a patient who has visited forest, and here they just want to ask me DDs of a lesion which forms an eschar. Okay, so these are the differential diagnosis of eschar forming lesions. What do I see here? I see a eschar, I see an ulcer which is covered with a necrotic scar. An eschar, this is called as necrotic crust, is also called an eschar. So what are the differential diagnoses of eschar forming illnesses? They are spider bite, they are post-trauma, they can be spotted fever, rickettsiosis or scrub typhus, tularemia, anthrax and disseminated fungal infection. So please remember this. These are my DDs of eschar forming illnesses. Okay. Now if I go back to the question, anthrax, scrub typhus and spider bite, they can all lead to eschar. But my KFD or Chiasanur forest disease does not present with eschar. What's Chiasanur forest disease? Very briefly, it is a tick-borne zoonotic disease which causes acute febrile hemorrhagic illness and is seen commonly in southern parts of India. This is caused by KFD virus, which is belonging to the genus of flavivirus. Now here we have hemorrhagic manifestations, not eschar. So in the skin, what I see is oral mucosal inflammation and non-tender maculopapular eruptions of a soft and hard palate. There are no specific skin lesions or rashes which are observed. Okay, so my KFD is not a DD of eschar forming illness, and so that would be my answer here. It was a little tricky, but remember these are my differential diagnoses of eschar forming lesions: spider bite, post-trauma, scrub typhus, tularemia, anthrax, and disseminated fungal infection. Clear? Just we'll go through one or two more questions. Which of the following is used as nail lacquer for fungal infections? Now in fungal infections, we know that there are different agents we use. In the topicals, we have creams, we have shampoos, we have nail lacquers. Now there are two main nail lacquers that we use. They are cycloperoxolamine and I have emerolfin. Emerolfin and cycloperoxolamine are my two nail lacquers that I use clinically. So let's look at the option: fluconazole, cycloperoxolamine, itraconazole and terbinafine. Even if you do not remember the name, you know that fluconazole, itraconazole and terbinafine are oral and medicines, and terbinafine also comes as topical agent, but cycloperoxolamine is used as nail lacquer. So here my answer would be cycloperoxolamine. Identify the phenomena shown in the image. What do you see? You see very, very scaly papular lesions which are present along the lines of trauma, where you have scratched. What is it? It is isomorphic phenomena, or also called as Koebner's phenomena. Isomorphic phenomena or Koebner's phenomena. Reverse isomorphic phenomena is when lesions improve on trauma. Gottron's papules, we just studied, is a feature of dermatomyositis. Nikolsky sign is something different that we see in pemphigus group of disorder, where when you put a shearing force, tangential force along a hard area of the body, the skin splits and forms erosion or blister. Here I am seeing lesions along the lines of trauma. Very, very easy. It is Koebner's phenomena, which is also called as isomorphic phenomena, because same morphology lesions develop along the lines of trauma. Same lesions morphology. Identify the conditions shown in the image. What do I see in the image? I see a lesion which has three typical zones. A central zone of atrophy, a central zone of activity where I can see some scaling, I can see perifollicular flugging, and a zone of pigmentation surrounding it. These three zones are typical of DLE. Let's look at all the options. So this is DLE, where you have three zones: central zone of atrophy, then a middle zone of activity where you can see telangiectasias, perifollicular plugging, scaling, and a peripheral zone of pigmentation, which is more of violaceous to hyperpigmentation. This is my malar rash here, in the butterfly distribution, sparing my nasolabial fold. This is rosacea, where I see erythema with telangiectasias. So this is a classical three zones that I see in the image. This is a patient of DLE. Okay, identify the condition. What is it? I am seeing here a lesion which is annular, which shows central clearing. I have central clearing, I have an annular lesion with periphery showing some amount of activity. This is typical of tinea corporis. Now, look at the lesion. Annular lesion may also be seen in granuloma annulare, but here I have no surface changes. I have no scaling. Pyoderma gangrenosum, presence with a gangrenous, it's present with an ulcer, with a necrotic ulcer. Ichthyosis vulgaris does not present like this. So this is a typical lesion of a tinea which presents with annular lesion showing central clearing with erythema, with scaling, with peripheral activity. A 25-year-old male presents with grouped vesicles over lips. So grouped vesicles present on the lips is nothing but herpes labialis. Again, very, very clear cut. Impetigo contagiosum presents with superficial crusted lesions. Bula, which has ruptured, forms coalescing erosions. Nothing similar. Vulgaris, we have already talked about. Varicella zoster, we know is present in dermatomal distribution. So vesicles present on the lips is herpes labialis. Okay, a patient presented to the OPD with complaints of papular lesions over the extremities, and on examination, lesions were soft and non-tender. Soft, non-tender lesions, papular eruption. So, image is provided. What is it? Again, very, very clear cut. We are talking about what's here. What's here? Or verruca vulgaris. So, this is common warts. Let's look at all the options which have been provided. Molluscum presents like this. It can be painless. It can be painless, but it presents with umbilicated papular lesions. Umbilicated papular lesions. Condyloma lata and condyloma acuminata presents in the groin area, in the perianal area, and the genital area. Condyloma acuminata is a type of HPV which will present with verrucous lesions. Condyloma lata is a type of secondary syphilis which will present with moist erosions on the folds, on the flexural area. So, it will present on the perianal area. Here, I have papular lesions which are present over the extremities. So, this is ruled out, this is ruled out. Molluscum can happen. It can present with papular lesions, but they are umbilicated and they do not look like this. This is a picture of common warts or verruca vulgaris. Okay. So, I hope these questions and their discussions were clear to you. If there is any other question that you want us to answer, I'll give you my email ID. You can email me on that and I would be happily willing to answer to your queries. These previous year questions and the discussions is very important because a lot of time we see the topics being repeated or even the questions being repeated. So our advice, please go through these previous year questions and revise them before your exams. Thank you.